as people logging in and joining the webinar. Thank you, everyone. This is our second webinar of the year, and it's about endometriosis tips and tricks. We have a fantastic program with fantastic speakers whom we are so grateful for their time and effort and expertise and kindness in sharing their experience with us. To introduce myself, my name is Multimodal. I'm co-founder of Gynae Fellow, and I'm blessed by having a fantastic team around me as well, who are helping and carrying this program forward. I would like to thank all our participants who are joining us, and I can see the numbers are coming up. Special thanks to our speakers, Professor Mechsner and Professor Mabrouk, for accepting to give the talks. Our moderators, Pele, Sarah, and Uday, who kindly will moderate the webinar, and Pele kindly agreed to chair the session today. Just few little points. This is a CME certified webinar. 2.5 CMEs are accredited by the Royal College of Surgeons, Edinburgh. We will offer the certificates at the end of the webinar. There will be an evaluation form where the team are going to circulate. Please fill the form, because the receipt of your certificate will be dependent on filling the form and the feedback. Final thank you words to our sponsors, Johnson and Johnson, for their support to this meeting. And also to the fantastic two, I call them, Mo and Anas, who are working in the background to make sure that the webinar is successful, addressing all the tech problems. And with the permission of the speakers, we're going to live stream our webinar to our social media page, so that in case people can't attend on Zoom, they can attend your lectures live on our social media page. And here I will stop, step back, and leave it for Pele to take over. Thank you.
Thank you very much, Mayad. And I hope everybody has been able to log in, and if you're not, then just join us. So I'm really delighted to introduce you to absolutely distinguished speakers who are just world-leading experts, both in surgery but also in research. Doesn't come so so much for. And first of all, our speaker is Professor Mechsner, who is a professor and head of endometriosis in Center Charité, Berlin University Hospital. And she has, pleased to look up on all in her research, because she's one of the leading basic researchers in pathogenetic mechanism in endometriosis, but also like excellent surgeon. So I'm delighted to give you the floor, Professor Mechsner, and she will be followed by Professor Mabrouk. And at the end, we will have questions and answers. So if anybody from you has some questions for both or one of them, please to write it up the chat, and we'll take them later on. Yes, thank you.
Thank you, Bile, for the kind introduction. It is a big pleasure for me to be part of this meeting today, and it's also a big pleasure for me to share our experience with the patients with ongoing symptoms, because that is often a big problem. Yeah, we all know we have two options. We can do surgery for patients with endometriosis, and then we have also the option to give them hormones or painkillers. And with the surgery and the medical treatment, we can improve the pain, but we have no chance to improve the infertility with hormonal treatment or painkillers. But the situation is that a huge amount of these patients goes on with complaints after surgical or with or under hormonal treatment, and that is a big problem for them. And also part of the patients have severe side effects or can't use hormonal treatment because they try to get pregnant. And we ask also our patients coming in our center what is the reason for them to come to us, and that we ask that in patients with already confirmed endometriosis, already treated endometriosis by surgery or hormones, and 90% of them came because of pain. And that is interesting. Also, patients with ongoing hormonal treatment suffer from cyclical pain and acyclical pain and other pain forms. And also patients, and of course, patients without hormonal treatment suffer from cyclical pain, but also from acyclical pain and other pain forms. And it's interesting because many patients have ongoing bleeding under hormonal treatment, and this bleeding is often painful for the patients, and that is also logical because of the adenomyosis and so on. And the patients have the feeling that this kind of pain is a cyclical pain, so they report also cyclical pain. But of course, they haven't a real cycle, and it's also an impression. On the other hand, especially in the case of hormonal treatment, the amount of acyclic pain is more than 55%. And patients with a real cycle have more cyclical pain than acyclical pain, but they have also acyclical pain. And I try to explain this with the next slide. But first, what can we do in this situation? We have the endometriotic lesions, and the lesions in the pelvis cause the nociceptive pain, but with ongoing symptoms and duration of the disease, also the central sensitization is coming up, and that means the nociplastic pain. And as you can see here, at the beginning, the nociceptive pain is more often than the nociplastic pain, but it's going together. So step by step we can rethink or we can think about the different options we have. We have the hormonal treatment, we have the surgery, but we need also to regard the pelvic pain management, and that means we need also the option of analgesics, of TENS, yoga, relaxing exercises, physiotherapy and osteopathy, nutrition, psychological therapy, and also complex therapeutical treatment options are available and have to be decided to introduce to the patients. In Germany, we have the private gynecologists and also endometriosis center. They can decide about the first steps of the treatment, and then we can also give the recommendation of other treatment options, and we have also the possibility to indicate an inpatient treatment for complex pain therapy. So in these patients, it's typical that they have, so they came with a treated endometriosis, so surgery was already done, and the situation is often that they have no organ damage at this side of consultation. no deep infiltrating lesions we can remove, for example. So they came only with the pain. And then the first step is to look for the hormonal treatment. Is that sufficient or not? And so we have to rethink if there is a hormonal treatment. If there's no hormonal treatment, then we have to ask, oh, excuse me, why not? Because of infertility? Yes, then we can't give the hormonal treatment because they need to go on with the infertility treatment. But then give them multimodal treatment. We can help the patients with painkillers and also lifestyle management changes. The other point, and that is very often here in Germany, is that the patients decline hormonal treatment because of personal reasons. So talk about it with your patient, because the endometriosis is an estrogen-dependent disease. We have a progression risk. We have the activity of the small lesions or the adenomyosis, and we have the risk of the chronification of the pain. And that is a very difficult point you have to explain to the patients. But I will explain in more detail later on. Or decline is does they avoid the hormonal treatment because of severe side effects? That is another point, because severe side effects, we need to find a good way for them to live with a good quality of life. And often depression or mood changes are the main problems why these patients avoid the ongoing hormonal treatment. And I think that is a critical point we have to talk about it. But then look for alternatives. So if there are the typical, in Germany we have the option to give Dynagest, it's covered by the health insurance, and the depression risk under Dynagest is around 5%. So then you can switch back to a combined oral contraception, for example, or you can try also desogestrel, which has also often lower side effects, or clobazam or dupaston or neta. You can try other progestogens, or sometimes also GnRH is possible. You have to try, but a very good option is when no systemic hormonal treatment is working for the patient, then you can try or think about the local hormonal treatment with the levonorgestrel iodine. So another problem is they have already the hormonal treatment, and then the most important question is the patient bleeding free? Because with most of the patients suffer from pain when they have bleeding. So if she's not bleeding free, then optimize the dosage or change the treatment. In case of progestogen only pills, the downregulation, the central downregulation, is often not it's not enough, maybe. So then you have to elevate the concentration of the progestogen. You can recommend a double intake, one in the morning, one in the evening, or you can switch to a combined oral contraception, or you can use also in long-term treatment. It's often a problem then often lower estrogen levels, so you can use also transdermal estrogen together with the progestogen only pill, or you can use the progestogen only pill and you insert a levonorgestrel releasing device in addition, or you can switch to GnRH, or you can switch to, or you cannot switch, you can use additional aromatase inhibitors. If she is bleeding free and has ongoing pain, then change the treatment too. If she is bleeding free and has pain under combined oral contraception, switch to a Dynagest only pill. If she has pain under Dynagest only pill or progestogen only pill, switch to the GnRH analog. because yeah, I know the worldwide the combined oral contraception is recommended for the use of for the treatment of patients with endometriosis, but we have sometimes a cumulative estrogen level under the combined oral contraception, and that this could be the cause of pain in this situation. And under progesterone, also in case when the patient is bleeding free, please check the sufficiency of the downregulation of the ovaries, check the E2 level, have a look for the functional signs of the ovaries. I will show you a case of our outpatient clinic. Or you can try GnRH, of course. And GnRH antagonist, we expecting the relugolix for next year also in Europe. That is it's available in Europe next year. Because the idea is quite simple. We give the hormonal treatment, we have the block, the central down regulation, so there is no estrogen, we have no endometrium, and that means there is an inactivity of the lesion. It's quite simple, but it's not always working in this simple way. When the patient, I always recommend to how to do. Yes, in case of progesterone only pills, it's no problem. You can recommend the double intake. In case of combined oral contraception, I don't recommend to do that longer than 3 to 4 days because of the thrombosis risk. But I always say to my patients, you start with the first bleeding. That's clear that there is a bleeding. And then normally the therapeutical amenorrhea is coming, but when you have spotting or the feeling that the bleeding is coming, go to 1 in the morning, 1 in the evening. Stop. If the bleeding is stopping, go back to 1 per day. If the bleeding is longer than 7 days, like in this situation, then take a break of 7 days with a withdrawal bleeding, because then the endometrium builds up in the most cases. You can check also the double endometrial thickness. You can look for functional signs, and you can check also the estrogen level in the blood. So to check the success of a hormonal treatment, the patients need to be bleeding free. Otherwise, it's impossible to know. That is the first step to find a good way for the patient. And I would like to share this case with you because it was really, really tricky. It's a 26 years old patient. She came with the diagnosis of endometriosis stage 2 and adenomyosis. She underwent surgery with excision of lesions 1.5 years ago. And then she came with a severe chronic pelvic pain syndrome. She had a permanent pain on the visual analog scale of 8 to 10, increased pain levels in association with the bleeding, and she was under long-term therapy with hydromorphone daily. She was unable to continue the education, and she had a permanent sick note. And then we excluded, we did our investigation. We excluded recurrent severe disease. We found no deep infiltrating lesions. Sliding was perfect, so no signs for adhesion. And then we decided to start with multimodal treatment and not to go on with the resurgery. We decided to optimize the hormonal treatment. We recommended the physiotherapy and pain management. So when she came, she had combined oral contraceptive, but irregular bleeding under the treatment, so it was insufficient. And yes, as I recommended before, we switched to Gynaecology, but the bleeding goes on. We switched to GnRH analog, the bleeding goes on. Then I decided, or I gave the recommendation also for psychosomatic treatment. She was she underwent inpatient treatment. She was willing to do everything, and they found also depression, of course, and the psychological distress, but there were no other psychological comorbidities they can work on. So we went on with the GnRH analogs plus Gynaecology and bleeding. I decided to give her Mirena bleeding, Mirena and Gynaecology bleeding, Mirena plus GnRH analogs bleeding. It was crazy, really crazy. And then, and all the time, the ovaries showed such functional signs, as you can see here, and here also functional cysts. Yes? And then I was thinking, or I was wondering if she was really, if the compliance was okay in this patient, but the GP gave the injection and the Mirena was still in. I did a measurement of the estrogen level. It was over 700, so really high. And then I decided to give her aromatase inhibitors in addition to the GnRH analogs. And after 3 months, no bleeding, pain improved significantly. She was able to reduce the hydromorphine. It takes 1.5 years until this happened now, and the estrogen level decreased now, and now she has an improvement, a really good improvement of her situation. But I was really wondering if the patient if the patient's compliance was accurate. But don't try to believe your patients. Yes, it's important. So yes, we have also to think about the resurgeries, of course. But when you have no hint for a recurrent disease, deep nodules, and so on, then my recommendation is to check the surgical report of the first surgery. Which procedure was done? How was the quality of the surgery? Did they removed all lesions? Or did they only diagnostic surgery with only coagulation of lesions? Is the staging correct? Check also the histological report. Is the number and the size of the lesions in agreement with the histological report? Because sometimes they reported, yes, excision of all lesions, but then you find in the histological report only 2 millimeter spots of tissue. So that is, yeah, you have to rethink about this, the quality of the surgery. Another point is, was the surgery done under hormonal treatment? Because in my experience, very small lesions are invisible under hormonal treatment, the peritoneal lesions. And then the pain improvement after surgery was only for a short time, and then the pain is coming back. Also, in case of good quality, ask a patient if the patient's pain improved or not, because that is also important to know. Because sometimes the quality of the surgery was excellent, but the pain is going on, and then another surgery makes no sense, because then the central sensitization is higher than the peripheral mechanism. Yeah, we do resurgeries only in maximum 7% of our cases, and find recurrent endometriosis only in 2 cases, and none of them use the hormonal treatment, one because of RT and the other one due to inability to take the hormones because of depression. The others had other reasons for the pain. One had an Endometriosis or chronic pelvic pain, central sensitization, no other lesions or severe adenomyosis. So yeah, the surgery in these cases was for nothing. In this case, we did a hysterectomy and then she improved. But otherwise, it's not always the right way to go on with resurgery in such cases. So please think about the reason of the pain. Is it a peripheral pain sensitization? Are there active lesions? Is it more the adenomyosis which causes the pain? Yeah, or is it the central sensitization? And what does this mean, the central sensitization? The typical cyclical pain in patients with endometriosis is a nociceptive pain. It's a release of prostaglandins, and that is the typical nociceptive pain, the dysmenorrhea. It's a cyclical pain, and it resolves after end of the bleeding. But when this pain is going on and going on and going on every month over many years, then finally the modulation of the level of the spinal cord changed. And because pain is always also an alarm signal for the body, it could be something dangerous pain. And when pain is recurrent pain is coming back and back and back, then the neurotransmitter release changed on the level of the spinal cord. And the first step is to expand an expansion of the nociceptive field. And that is a typical situation that also urination and defecation is then also painful. In the first time of the disease or the first years of the disease, it's also in cyclical pattern. But it could change to acyclical pain. And another point is also that the patients are looking for pain resolving positions, and there's also a strong contraction of the pelvic floor, and this is also a very important point. And finally, a normal input exaggerated to a strong response. We know that also the pain linked areas in the brain changed the morphology, and finally then the pain threshold decreased in such patients. And then the pelvic floor is so painful, also normal gynecological investigation is so painful for them. Intercourse is in many cases impossible then, because of the spinal hyperalgesia, and I call this also with pelvic floor dysfunction. That is in many cases then the situation. And that is important to recognize that there's a switch of the pain character in these patients. The endometriotic lesions are very active. We know that there are release of amounts of pain mediators, growth factors, inflammatory mediators. They have also the chemotaxis of immune cells. So we have immune cells infiltrate there. We have the neurogenesis, neuroimmune modulation, angiogenesis, lymph angiogenesis, and also smooth muscle metaplasia and fibrosis. So that they have many stuff to cause pain. There's many stuff to cause pain in the lesions. And another point which could be the cause of the switch of the more cyclical pain to acyclical pain, we call that neurogenic inflammation, because we know that there's a switch of the innervation. We have an outgrowth of sensory nerve fibers into the lesions, but a deletion of sympathetic nerve fibers, and by this the release or the amount of more pro-inflammatory neurotransmitters like substance P and CGRP changed in correlation to the more anti-inflammatory neurotransmitters of the sympathetic nerve fibers, sympathetic nerve fibers, and that means that there could be a neurogenic inflammation present in the lesion. And I think that is a point when hormonal treatment is not working anymore, so they develop the pain mechanisms more independent from hormones then. Yes, and that is finally then the situation. We have the visceral organs from the periphery, the input from the uterus, from the bladder, from the bowel, from the somatic area, the pelvic floor, the vulva, and we have the switch and on the level of the spinal cord with the changes in the release of neurotransmitters, and then patients develop the visceral hyperalgesia and also the somatic hyperalgesia, and then means that patients suffer from also other comorbidities, but they are all together. So painful bladder syndrome, IBS, pelvic floor dysfunction is often correlated with endometriosis, and I think now the reason for the development of such complex situation might be more clear. And it's not only psychosomatic problems of these patients. We can explain this development of these complex pain situations. So, of course, it's very important to have also adequate pain management. And in Germany, it's a big problem because nobody feels responsible for the prescription of painkillers. Who should give the patients a painkiller? But that is also another problem. But I would like to give you an overview. Yes, we have the known ibuprofen and naproxen, the typical anti-inflammatory substances. But here, please think about the stomach protection. Then we have the metamizole, but also buscopan and magnesium. And we have also the CBD oil. I would like to show you on the next slide that a combination of these three drugs makes sense. But in general, it's good to say the patient that she should follow a dosing schedule. She should start as soon as possible with the treatment. Patient shouldn't wait as long as the pain peak is already reached. That makes no sense, because then she needs a higher concentration of painkillers to resolve the situation. So, for example, give the recommendation of ibuprofen, 400 milligrams 3 times per day. If acquired, additional metamizole drops. Also, documentation should be done by the patient about the amount of painkillers. In Germany, it's, they can buy it by themselves, and some patients use huge amount of painkillers. It's unbelievable, and others decline the use of painkillers. They prefer to have the pain because they think it's too unhealthy to use painkillers. And also ask for more neuropathic pain character. It's more burning pain. Then you can start with gabapentin or pregabalin. It's often very sensible and helpful for the patient. But if the management with these compounds are insufficient, then I transfer them to a pain center, and we have to work together. Yeah, this slide should show you an overview about the work mechanisms. So we have the peripheral sensitization with the release of prostaglandins by the endometriotic lesions, and also, yes, the uterus is the mother, yes, and also the bowel. We have the smooth muscle cells here. So it makes sense to give a combination of ibuprofen, but also of metamizole, because it's more spasmolytic then. And metamizole has also central work mechanism. Another point is that CBD oil is working on vanilloid receptors. It's in the nociceptors. It could be block the nociceptors, but we need to know that the bioavailability of CBD is very low. So if you take the drops, only 20% came to the working place. So it's you need a huge amount of this. THC is also working on the vanilloid receptor, but it's not available in Germany, or it's really difficult to get it. And this works also on a central level. Gabapentin is working directly on the nerve fibers. Also procaine, you can use also procaine infusion. It's sometimes also sensible for the patient. And you can do also neurotherapy therapy with procaine injection or Botox injection into the pelvic floor, into the myofascial trigger points. Also, antidepressant makes sense, especially in case the patient can't sleep because of the pain, because it's very important to have good sleep. They have also an analgesic effect in patients with chronic pelvic pain, so you can add antidepressant also in the pain regime. Yeah, let me talk about the pelvic floor. Yes, we have a lot of changes, and the urogynecologists, other specialists, did a lot of research on the level of the pelvic floor. They investigated the tonus, the power, the endurance, the coordination, and or the ability of relaxation in patients with chronic pelvic pain, and they found such a lot of changes. And yeah, the research, the data are fine. That is very interesting, but the endometriosis specialists don't look into the data of pelvic floor specialists. So yeah, it's important to know that the pelvic floor changes are very severe, and we can treat them, because in this case we can do physiotherapy and so on. I would like to show you the Maple system. The Maple system is a probe. We can put it into the vagina, and then we can do an electromyography. And so by this, we will get a mapping of the pelvic floor muscles. And this is a patient with endometriosis, and as you can see here, this part of the middle pelvic floor muscles are very hyper contracted. And with this probe, you can try also or you can do a targeted electrostimulation of these hypertonic muscles. And as you can see here, after this treatment, the hypercontractility of this muscle resolved, and then the patients reported also that the pain level was lower afterwards. That is very interesting, and we started, we are starting a prospective randomized controlled trial in 2 months. We have an interventional study created with this probe, and I'm very excited about the results. But as far as we have this option for the treatment, you can give your patients the recommendation of pelvic floor relaxing exercises. Also, yoga is well established in the treatment of the pelvic floor hypercontractility. You can use also a biofeedback system. We can prescribe this for patients with incontinence, yes, because then they have to activate the pelvic floor muscles, and then we do the counterpart of this trial or of this probe. We can give the patient the option of relaxing exercises also with biofeedback information. And also osteopathia and manual treatment is very helpful in this for this indication. Also acupuncture is approved, and we have good results with it. Another point are the bowel symptoms the patients reported, and I don't mean bowel symptoms due to deep infiltrating lesions. I mean other bowel symptoms, because many patients are talking about abdominal discomfort, pain, constipation, bloating, diarrhea, cyclical bloating, the urge to have a bowel movement, and that has an impact on daily life. And we know that they have also a high coincidence with IBS. and they have often, or they reported often, about gluten sensitivity. But why is this cyclic? I can't understand why these changes are cyclic. And I looked, and this is a typical endobelly patients of our center. She sent me so many patients bring pictures about their endobelly, and yeah, that means the cyclical bloating, and sometimes it's the most dominant symptom for the patient. So we have to find a solution for this. And yes, I told you I was wondering why these changes are cyclic, and I looked for the regulation of the bowel motility, and I was really surprised that it's more complex than I believed before. But it's very interesting that there exists also sex differences, and that the bowel motility is also influenced by the hormones. So that is really interesting, I think. And then I found this paper about this topic from 1998, so 13 years ago or 14 years ago. And that was a really interesting investigation, because they inserted a probe into the stomach and the duodenum of patients, of non-endometriosis patients and endometriosis patients. And then here you can see the regular contractility pattern in non-endometriosis patients, but a very irregular contractility pattern in patients with endometriosis. And by accident, they found also that 40 of the 50 patients had a small intestine bacterial overgrowth, maybe also involved in this situation of patients with endometriosis, but there is not so much, there is no literature about this topic available so far. So I think it's really interesting, and we have to rethink about it. So what is helpful now? There are no clinical trials available. What is helpful for the bowel problems? So my recommendations are based on patients' reports. We have the experience that the vegan food is better than a normal or mixed food. No sugar, no gluten is very helpful for the high amount of green vegetables, bioproducts, of course, and also probiotics can reduce the symptoms. Maybe, yeah, we know that the amount of gram-negative bacteria are higher in patients with endometriosis. Maybe this leads to a higher amount of lipopolysaccharides, which mediated also the activation of macrophage. But it's an idea, I don't know exactly, we need more data about it. And also low level of histamine, because this is also a pain mediator, is helpful in many cases for these patients, and many of them then reported about good pain reduction in this case. Another point is that endometriosis is a pro-inflammatory disease. We have the oxidative stress. So also unsaturated fatty acids should be recommended because they have an anti-inflammatory profile, reduce prostaglandin synthesis, and there exist also prospective studies that is well established by Stacy Mechsner from US. Also, the vitamins and antioxidated vitamins are sensible, and also there exists also a couple of studies with the vitamin D. Also, the work mechanisms here are the anti-inflammatory effects. And of course, the pain the situation is very complex, and it's stressful for the patients. And we investigated also in our patients the number or the amount of depression, and especially the patients with acyclical ongoing pelvic pain have a higher risk for depression. Also, we know the cortisol is elevated and involved in the stress regulation. So at this point, it makes sense to involve a psychologist to show, to give the patients more support, to give them the idea of pain, to learn pain coping strategies and so on. It's very important to involve also the psychological aspects of into the treatment. And for the last group of patients, nothing helps. Then we started also a study set up for complex therapy as inpatient module at Charité, and we had them 2 weeks as inpatients in the inpatient treatment with a full schedule of physiotherapy, psychological meetings, group meetings, learning progressive muscle relaxation, pain education, art therapy, neural therapy, osteopathy, and so on. And that improved the situation of most of the patients very much. They were very satisfied. This was a art work of one patient, and this picture touched my heart really, because I think it shows really what it means, endometriosis for a patient. Painful bleeding, painful pelvis, and green, that is a hope, that the color of hope that the uterus will get pregnant. And this patient she has given birth to a girl. Now she is fine, and she had so much pain before. Yes, and finally, I would like to share one case of our outpatient clinic, because I think it's very interesting, this case. She was a 37 years old patient. She had the history of a primary dysmenorrhea, started more than 20 years ago, always heavy menstrual bleeding, recurrent bladder infection and pelvic pain. So she started at the age of 19 with the combined oral contraception. First, she took it in a cyclical modus, which is typical with withdrawal bleeding, but the withdrawal bleeding was painful. That is also really typical for patients with endometriosis. Not such worse than before, but painful. She switched another progesterone only contraception, but and that worked better, or worked. It was better for her, but she stopped because of skin side effects. And then she had no further treatment, but then she had recurrent symptoms. She started again with combined oral contraceptions, and in 2014 she developed a thrombosis. So she started with Xarelto, and of course she stopped again the combined oral contraception, recurrent pain. Then she suffered from acute abdomen with fever, so she underwent laparoscopy because of appendicitis. Appendectomy was done, and by incident there was a diagnosis of endometriosis. So she underwent the first surgery for endometriosis, but afterwards she suffered from ongoing pain and also dysfunctional bleeding. She started with a progesterone desogestrel, but that is also often ongoing bleeding under the hormonal treatment. The second laparoscopy was done only with probes, no clean out, no pelvic clean out, and post-operative ongoing pain. Then she decided to try to get pregnant. She tried for 1 year, unsuccessful. Now she's separated from the partner. Severe pain again. Then the gynecologist gave her GnRH analogs, but without add-back hormonal replacement therapy. In this situation, she had no bleeding and no pain. So it was the first situation for her after more than 20 years that she was pain-free. But she suffered from severe side effects, hot flashes and so on. Then she suffered also from a herniation of the cervical spine, so also other problems came together, and she had no capacity to think about the endometriosis again. So she was under GNRH analog for the half year. Then the third laparoscopy was done under GNRH analog, and surprise, surprise, there were no active lesions visible. So they said to her, there is no endometriosis anymore, and they gave her Chilena, which is a medium levonorgestrel releasing device. So GNRH analog stopped, and yes, the bleeding came back. And with the bleeding, also the pain. She had also dyspareunia, polykisuria, and unspecific bowel dysfunction. And then she contacted me because hysterectomy was scheduled in another hospital, and she wanted to ask if I can use her uterus for research. Yes, she sent me an email. Please, I will give you my uterus. Please get it. I don't want. I'm not willing to lose the organ without any sense. And so I invited her to come for consultation in my outpatient clinic, and her private gynecologist gave her the strong recommendation for hysterectomy. She had no other chance to get pain-free, and beside of this, she is unable to get pregnant. So I did the examination, and yes, the pelvic floor was dense and extremely painful, and she had severe adenomyosis, so a thickness of both sides of the uterine wall, but all the other findings were normal: good bowel movement, good sliding, no hint for deep infiltrating lesions. So what to do? Surgery, yes or no? Should we go on with hysterectomy? And I go back to the history because I want to show you now the critical points in her history. The first one is 20 years until diagnosis has to be confirmed, and during this time, insufficient therapy. So that is the cause for the chronic central sensitization. Yes, the hormonal treatment was always insufficient. The desogestrel was not enough. She has the ongoing bleeding. The GNRH analogs, that was the first good idea, but without hormonal replacement therapy, no thank you, it's not an option because of the side effects then, but no bleeding, no pain. So there's also the peripheral pain present in her case. The pain is sensitive for the hormonal treatment. That is very important to recognize in this point, at this point. The third laparoscopy under GNRH analog, that makes no sense. That is a very, very old concept. And Chilena, it's not enough. The hormonal dose is too low to bring the patient in a therapeutical amenorrhea, and of course she had the bleeding again. And no recommendation for RT. That is also not nice. A 37 years old patient. And then I asked her if she has still the desire to have children. Yes, of course she has, but she has no partner at the moment. And that is also really, really critical point to plan a hysterectomy. No, I don't wanted to do that, and I told her. And then, yes, we postponed or canceled the hysterectomy for this point, and I give the recommendation to exchange the Chilena against Mirena and plus desogestrel because low side effects and allowed in case of history of thrombosis. Excuse me. But the rescue option is go back to GNRH analogs again, but then with at-back hormonal replacement therapy or to switch to Gynaecology. But she is now bleeding free under this double treatment with Mirena and desogestrel. And we give also the recommendation of multimodal treatment, the pelvic floor relaxing exercises, osteopathia, yoga, ETS, painkillers, food changes. And now she's bleeding free. The pain level decreased down to on the 2 to 3 on the visual analog scale, and she can live with this situation. So she has a little bit more time to find a partner or to whatever, think about her situation, and now she's satisfied. So let me close this session or this talk. I would like to show you, it's a multimodal personalized treatment concept we have to create for our patients. Of course, we have to think the hormonal treatment, the surgery, and also the family planning situation. And then we have to add all the stuff I showed you, but that takes time. Yes, it takes really, it's a time-consuming work, of course, because it takes an hour or whatever to explain all these aspects to the patient. And yeah, in some special situation, we need also the pain management or the complex therapies. And yeah, we urgently need more health services research in this area, because we have a lack of data. And yeah, we have to optimize the situation for these patients. And this is really my last slide. I would like to show you this because it's from our basic research. It's dorsal root ganglia from a chicken embryo, and it's incubated with the peritoneal fluid of patients with endometriosis. And what you are seeing here are the sensory nerve fibers outgrowth induced by the peritoneal fluid. Yes, in case of non-endometriosis patient fluid, there are no nerve fibers. Yes, and now I thank you for your attention, and yeah, we can discuss later.
Thank you so much, Professor Mechsner. That was unbelievably very complex overview of the disease and how complex it is and how many things we have to, tackle there, and also like the research around it. And excellent. Thank you so much.